Hey guys, it's Dr. Crad. Here's a cataract patient with 16 cut RK surgery. With an 8 cut RK, you can usually fit your incision between two of the RK cuts. But that's not the case with 16 or 32 cut RK surgery. In these types of cases, you need to make a scleral incision because you don't want your incision to connect to one of the RK incisions on the surface of the eye. That can cause the RK incision to easily gape open. Some doctors perform a conjunctival peritomy first, which is fine. Some other doctors create a straight pass through the sclera, but that can lead to chemosis or conjunctival swelling, which can get in the way in subsequent steps of the surgery. In this video, I will show you my approach. A millimeter or two posterior to the limbus, I create a groove first, which is wider than my incision width. This will prevent chemosis of the conjunctiva. Then I create my incision within the limits of this groove. You're simply trying to create a gap between your main incision and the border of the RK incisions. You see how there's a gap here between the edge of the incision and the RKs? And you should get no closer to the limbus than this. In fact, consider going even a half a millimeter more posterior than I did. If you do this, then most likely the rest of the cataract surgery becomes routine. Keep in mind that you need to avoid increasing the eye pressure too much, so don't overinflate the eye with viscoelastic, and lower the eye pressure or the bottle height on your phaco emulsification device so that you don't cause the RK incisions to dehiss. So here I'm performing a capsulorhexis manually. So what are the considerations when choosing a lens implant for a patient post-radial keratotomy? What is the best lens and what should your refractive target be? Currently, I would have to say my favorite IOLs post-RK are either the light adjustable lens or the IC8 Apthera, also known as AcuFocus by Bausch & Lomb. In terms of refractive target, definitely aim more myopic than you would expect, because most patients tend to have a hyperopic surprise. Also, the swelling at the RK incisions can cause a temporary hyperopic shift in the prescription for the first month or two after cataract surgery. So when implanting a light adjustable lens, you don't want to do the adjustments too early. You want to make sure that the refraction is stabilized and no longer shifting so you don't get a surprise after you lock in the lens. So when do we choose the light adjustable lens versus the AcuFocus or IC8 Apthera lens? If a patient has very high irregular astigmatism, light sensitivity that is attributable to their cornea, then I would choose the IC8 Apthera because the pinhole effect that it has will decrease scattered light and it will give them depth of focus. However, I would expect the residual refractive error to be less with the light adjustable lens. So if a patient has a less irregular cornea and doesn't have too much light sensitivity, then I would go with the light adjustable lens. And you can mix and match the lenses. For example, you can put the light adjustable lens in the dominant eye and the AcuFocus in the non-dominant eye. In this case, the patient chose a basic monofocal lens due to the high associated costs with the light adjustable lens and the IC8 Apthera. And that's an okay choice. However, the patient will be more dependent on glasses when using a basic monofocal lens. And have a low threshold for placing a suture at your incision, although in this case I decided I did not have to. So here is the patient 1 week after surgery. Preoperatively, she had a 30.1 millimeter axial length. She was minus 17.25 plus 6 at 176, and her best corrected visual acuity was about 2400. I implanted an Eyhance lens and aimed for a minus 1.23. At 1 week post-op, her autorefraction is minus 1.5 plus 5 at 169. She is very happy with her uncorrected vision of 20/70, and after about a month of healing, we will check her manifest refraction and best corrected visual acuity. That spherical equivalent is about a +1, much more hyperopic than the minus 1.23 target, but I do expect some of that hyperopia to melt away over the next month or so. I hope you found this video helpful. Thank you so much for watching. I'll catch you on the next one. Peace.